Hey, good evening, everyone. We'll go ahead and get started while we allow folks to trickle in. Thanks so much for joining us for our third session of the 2023 Harvard Surgical Ethics Conference. I'm Teresa Williamson. I'm one of the co-chairs of the Harvard Surgical Ethics Working Group and a neurosurgeon at Massachusetts General Hospital. Tonight, we have a really exciting topic. We're going to be talking about the ethical implications of new biomedical devices and technologies in neuroscience. We have with us two phenomenal experts, Dr. Francis Shen and Dr. Gabriel Lazaro Munoz, who are going to be sharing with us some of their expertise regarding these topics. And I also will be discussing some of the neuroscience topics in neurosurgery. Just a couple housekeeping announcements. So first of all, just thanks again for joining us. If you want to submit any questions, and we encourage you to do so throughout the presentations, please go ahead and do so in the Q&A feature. We will be monitoring these throughout the discussion, and then we'll just have a discussion period for about 30 minutes at the end. So your questions will get answered and discussed. If you have any technical issues, that's where we're going to use the chat feature. So please go ahead and send a message to all panelists and hosts, and a staff member will be able to help. These slides and presentations will be recorded. If you want to continue the conversation with us online, please follow us at the HMS Center for Bioethics and hashtag HMS Bioethics in your social media posts. And then if you're interested in any other bioethics news, webinars, or educational programs, the website there is below. Okay, so we will go ahead and get started. The first speaker that I'm going to introduce is Dr. Francis Shen. Dr. Shen is a member of the faculty here at the Center for Bioethics in Department of Global Health and Social Medicine at Harvard Medical School, also a faculty member in the Department of Psychiatry at Mass General, and a Harvard University affiliated professor at the Harvard Law School. He runs a lab where he explores the emerging intersection between law, ethics, and neuroscience, and the lab motto is "Every story is a brain story." Dr. Shen has co-authored 3 books, including the first law and neuroscience casebook, published a plethora of articles, and received a lot of funding and recognition in the space of neuroscience, law, and ethics. He is currently leading the creation of a Dana Foundation Career Network in Neuroscience and Society, and co-leads projects on portable MRI, the ethics of digital phenotyping in psychiatry, and pursuing neurotech justice, improving neuroscience training for judges. In 2001, he was awarded the Early Career Scholars Medal by the American Law Institute, one of 2 medals awarded every other year by ALI, for being a pioneer in establishing the interdisciplinary field of law and neuroscience. Dr. Shen trained at the University of Chicago and received his JD and PhD from the Harvard Law School and Harvard University. So without further ado, I will stop my share and give him an opportunity to share his slides. Thanks so much.
Thank you, Dr. Williamson. Thanks, Dr. Hanto. Thanks to everyone for organizing this wonderful event. And it's great to participate. And it's great to collaborate with both Dr. Williamson and Dr. Lazaro Munoz on some of the work that I'll talk about today. I'm going to focus my comments today around the connection between community engagement and surgical bioethics, with anchoring on the case of neurotechnology. This image, which I hope is evocative, is from work that the project that the 3 of us co-led earlier this year and at the end of last year produced. I'll talk a little bit more about it, but these are youth and some of their colleagues at a group called More Than Words. If you're here in Boston, you can go to the bookstore and buy your books there, talking about neurotech, talking about the very issues that we're talking about today. And I'm going to come back to that theme. No disclosures, thanks to all of my funders, and the views here are all my own, none of the funders. So I'll give you the punchline up front. I'll give you a little quick introduction to my work. I want to do one brief historical reflection to provide some context for 3 questions that I think patients might ask you someday as neurosurgeons, and to think about how you might answer them. And then I want to talk at the end, to come back to that image, and talk about what does neuroethics look like in action? What does community engagement look like in action? And introduce some of the work that we're doing in the Center for Bioethics to address that. All right, so let's start at the beginning, though. Sometimes neuroethics, bioethics is seen as the ethics police, and I think nothing could be further from the truth. In my view, neuroethics is a reflexive practice, fancy words for saying it offers an opportunity for us as a community, for you as neurosurgeons, and think about whether the things that you're doing and how you're doing them are consistent with and aligned with the values that you hold. Neuroethics, as I'll talk about today, helps us to see that the work you're doing as surgeons doesn't happen in a vacuum. Those patients come from a place, they go back to a community, and neurotech is also emerging from and being implemented in particular communities, and not in certain communities. So neuroethics is not here to stop progress. Indeed, everything I'm going to talk about today is like encouraging innovation in neurosurgery, but thinking about the ethical, legal, and social implications that may emerge. The punchline is this. I think we can all agree, I hope, that advances in neurotech will raise novel ethical and legal questions, and you're going to hear some more from my colleagues about some of those. I'll talk a little bit about informed consent, race bias, a little bit on privacy, and then really think about, well, how do you address these? How do we address them? And suggesting to you that community engagement as a process, as a method, may be one promising avenue to pursue. All right, quick introduction to my work. Dr. Williamson, thank you for the kind introduction. As you said, we run a lab, and it is focused on the brain and AI, law and ethics. Our motto is every story is a brain story. The challenge is, of course, so that every story is not a fully understood brain story, and relevant to the rest of my comments, every story is not just a brain story. It's a story about culture and history and relationships, and much more. We pursue two big questions, and the big one that I'll focus on today is how law and ethics inform, regulate, engage with neuroscience, neurosurgery, and AI. In other talks, we sometimes think about how can we leverage all that cool stuff in neuroscience and AI to change the law. But today, the arrow points this way. Collaborate all over the place. So if your students want to get involved, if you want to join as a co-author, you can join. I sometimes joke that when I travel, I don't pick up souvenirs, I pick up co-authors. So come join us in this interdisciplinary exercise. All right, so a brief look back at history. And I preface this by saying, again, that I'm bullish on the future of neurotech. I'm bullish on the future of neuroscience and AI, but I'm also really cognizant that there have been many instances in the 20th century, maybe go before that, where neuroscience has been leveraged not for the good. And I just want to give you a couple of examples specific to neurosurgery, not the type of neurosurgery you may do, but to neurosurgery. So in the late 20th century, in the 70s and 80s, late 60s, brain surgery emerged in part, some thought, to control behavior. It was of great concern, reaching the cover of Ebony magazine. If you can read that, brain surgery to control behavior. And it's the headline above is New Threat to Blacks. I'll give you a couple of examples to see what this looked like. There has been fascination about the violent brain for many years. Our colleagues, Adrian Rain, University of Pennsylvania, a wonderful colleague, wrote a book in 2013, The Anatomy of Violence. But I want to focus on this earlier period where MGH and Harvard professors and surgeons, Vernon Mark, Frank Irvin, wrote Violence in the Brain and really tried to think about how psychosurgery could improve social outcomes. There was a book that sort of summarized their work and the movement at that time. Is called The Mind Stealers. And I'll just give you this quote. A so-called scientific rationale is being spawned to explain the critical dilemmas of the day, such as the rising tide of violence. Sound familiar? With the public demand for speedier solutions to the crime wave. Sound familiar? Such as a burning desire for a tighter national budget. Sound familiar? This is 1978, but it could be today. And in that context, psychosurgery emerged and became attractive on the grounds that, boy, the brain controls behavior. We have a lot of disturbing behaviors in our society, so why not intervene surgically at the level of the brain? Now, thankfully, this psychosurgery didn't take off at that time. We simply didn't know enough. Quite problematic for another day. But I want to give just one more example to show that the work of surgeons can show up in a lot of places outside of this, the surgery environment. This is Egas Moniz's commemorative stamp. Of course, he won the Nobel Prize for the prefrontal lobotomy. You know that the lobotomy is extremely problematic. What you might not know is that colleagues in law, in the legal system, were paying attention. And much like in the 70s, where they thought, boy, psychosurgery isn't just for medicinal purposes, it could be for societal purposes. So too did they think that in the late 1940s. There's a quote from the Yale Law Journal, which for the surgeons on the call is sort of the equivalent of publishing in Science or Nature or JAMA. It was a big deal. And the commentators there thought that psychosurgery has startling implications for rehabilitation. Perfection of so relatively simple and inexpensive a technique as a prefrontal lobotomy promises to be a major contribution to the cure of criminals. Now, thankfully, it was never implemented at widespread, though in a few court cases it was. And I conclude our historical journey here simply to keep us humble, right? So we don't always know as much as we know. And second, to say that, again, the things that you're wrestling with as surgeons maybe spill out into society in a lot of ways. And we trust you as surgeons tremendously. So the ethical duties you have are heightened. Okay, so let's fast forward from the 1940s and the 1970s up to 2023. And as I was preparing this talk, I thought, how did I want to frame it? And I decided to think about, what if I were a patient, one of your patients, and I was being fitted for one of these new advanced neurotechnologies, one that is closed loop, perhaps something like responsive neurostimulation for treatment-resistant epilepsy, something else in that bucket. Closed loop, a lot of AI, very fancy, a lot of data floating around. What kind of questions would I want to ask? Now, we've thought about this before, and I want to give a shout out to all of our crew. These were students and fellows, colleagues who worked with us in the Dana Foundation Center for Neuroscience and Society Planning Grant for 5 months. An amazing work, and produced this article, Advanced Neurotechnology and Informed Consent in Neurosurgery, Ethical and Legal Perspectives. I'm going to say a few words about that, and then a few words about some related topics. So a quick refresher on informed consent. It has roots in both law and in ethics. In law, there is a standard of care that requires, of course, informed consent. Exactly what is required depends on the jurisdiction. Some require, what would a reasonable physician say? Some say, what would the reasonable person or patient require? And some actually use a subjective standard test. It's also rooted in ethics, and in particular respect for patient autonomy, that in order for them to make a free and informed choice, they need you to provide some information. For those who are involved in research, surgeons, the regulation of research, the common rule in the United States applies, and requires that information must be presented in sufficient detail and organizes and presented in a way that does not merely provide lists of isolated facts, but rather facilitates the prospective subject or legally authorized representatives' understanding of the reasons why one might or might not want to participate. So this should ideally, this informed consent process should be more than just read it, sign it, let's get going, but involve some dialogue. And I imagine, as I said, 3 questions. So here's question number 1. You're going into surgery, and the patient is saying, Dr. Williamson, Dr. Hando, doctor, can you please explain to me again, how does this thing work? Now, you deal with complicated technology all the time. You've been doing it your entire careers, but things are getting even more complicated. Advanced neurotech, and this comes from work that Gabe, you're going to hear from Dr. Lázaro Munoz in a second, one of the working groups he's with has published. And I like it because there's stuff everywhere, right? Here's the closed loop, right? Getting the biometric data, responding and deciding how or how much not to stimulate. And data is going outside here. It's connected to the cloud. The researchers, the physicians may have it. It's connected to a phone. Stuff is moving everywhere. And as we say in this article, no single neurosurgeon, is quoting from a colleague, can master all of these domains, as talented as you may be. You're not an expert in all of this. And so answering this simple question, how does this thing work, is really tough. All right, and I could say more, but in the interest of time, let me go to question 2. So now your patient says, okay, I get a sense of how it works. I get that. But can you just remind me, who's going to have access to the data from this device? And again, this question had an easier answer just 5 years ago. But today, this data is being collected on some of these devices always. This is just one example from NeuroPace, and not promoting any particular product. They'd all want to let you know that this is monitoring your brain actively 24 hours a day. And when you have a device in a brain measuring brain activity 24 hours a day, 7 days a week, guess what? It's not just medicine that pays attention. The law does also. Remember our historical examples? So here's a case study that hasn't happened yet, but I guarantee it will. It's just a matter of time, and it might happen sooner rather than later. There's no published case yet about what I'm going to say, but there are similar cases where courts have admitted data from always-on smartwatches, fitness trackers, and even pacemakers. So imagine that you've performed neurosurgery on your patient, and you've implanted an always-on, always recording DBS neurostimulation device. Sometime later, your patient is now a criminal defendant, and they've been accused of assaulting Y after a fight. The primary defense is that, oh, it wasn't me, I was sleeping at that time. Well, the prosecutors want to know, let's see your data from your always on, always recording DBS device, and let's see if your brain activities suggest that, yes, you were sleeping at that time, or in fact, it does not. The defendant, of course, doesn't want the government to have access to their brain data. And now I want to zo back. What about when you implanted that device? And they ask this simple question, doctor, who will have access to the data from this device? Are you ethically or legally obligated to discuss the potential surveillance aspects of a smart DBS device? Open question. Again, if we had more time, maybe in discussion, we can. In the interest of moving on, I'm going to just raise a third question. What if your patient asks, has this device, or just, one final question, really is my last question, my third question, has this device been tested on people like me? Now, this is a really tough question to answer because, of course, we all have a tremendous number of identities, a gender identity, an age identity, a geographical identity, an ethnicity, a race, and so forth. And there's been a move in many areas, including neuroscience, for more representative and diverse data sets to avoid bias. But we don't know exactly what that means. That is, if it's been tested on 50-year-olds, it's probably good for 40-year-olds, right? It's not biased towards 50-year-olds, we think, and it's difficult to know. I want to give just one example, though, to think about procedural justice, because sometimes it doesn't matter. Let me just jump ahead. It doesn't matter, even if the device seems to be well tested. There could be a procedural justice question. And here's the silly hypo, but I think it will ring true. So outside of neurosurgery, there's a professor colleague, and they want to predict in their algorithm whether humans can jump 10 feet off the ground. Now, we all know this hypo has an answer. No human can jump 10 feet off the ground. So Professor X takes the first 30 people who walk in the door. They're in a diverse place. It's 30 diverse people. And it turns out that every time, for every human, their system correctly predicts you will not jump 10 feet off the ground. Well, Professor Y and Z come to the same conclusion with their algorithms, only they arrive at that conclusion in different ways. Professor Y is in a non-diverse locale, so all of Professor Y's participants happen to be white. But again, race and ethnicity don't matter for predicting whether you can jump 10 feet off the ground, so they end up in the same place. Professor Z, however, only invites white people to participate in the study, even though there are others. And because of Z's racist recruitment strategy, all 30 participants are white. But guess what? The algorithm at the end works just the same as Y's algorithm and X's algorithm. Now, if there's some part of you that thinks, Z doesn't sound exactly like the sort of colleague I want to have, and I don't like this algorithm, but it doesn't seem statistically biased, what gives? Well, one thing that may give is something called procedural justice. Thinking about the way in which patients in a surgical context are treated, thinking about the way that clinical trials are run. And I would just raise the question around procedural justice in neurosurgery to think about what procedures are being used to communicate with patients, to engage with the public, to recruit participants to DBS studies. And are we satisfied with these procedures? Procedural justice, again, is different than just looking at surgical outcomes. It's looking at the process by which we got there. All right, I've got maybe a minute left, and that's enough for me to give you a preview of what it looks like to do neuroethics in action, because all of the questions I just raised are really difficult to answer. And I want to suggest to you that rather than just smart people in a room coming up with the answer, it ought to be smart people with really smart people in the community as well engaged. There can be a danger, the illusion of participant engagement. Best practice is robust and thoughtful engagement from the beginning through the end. Worst practice is to involve no patients, participants, or community members. But a really concerning practice, which I have seen not infrequently, is using it as cover or checkbox. Oh yeah, we had a community advisory group. They said it, so we're good. No, it can't be the illusion. It's got to be real engagement. And we're trying to do that. We hope you will find more about this information than I can say now. You can go to neurotechjustice.org, learn about the summit we held in January. These are some of the participants. We engage lawyers and neurosurgeons and judges and ethicists thinking about this trajectory of the advanced neurotech. I just talked about it. How do you ensure that it is not just advancing, but advancing for the good of all? And the core, we think, is this participant-centered and community-engaged research. If we have time during discussion, we can talk more about some of the plans we have for trying to expand this, hopefully, into a full center for neurotech justice. But I'll just end by saying that getting out there in the community is really important. These are some of the methods we use. Sometimes you survey a bunch of people. Sometimes you talk with folks, which we've done at the Museum of Science. So there's Gabe and Teresa and us all engaging. And I'll end with this set of images that I started with. This is our collaboration with More Than Words, a nonprofit social enterprise. They empower system-involved youth to take charge of their lives. And we played a game called Neurofutures. We looked at these cards. This is one example of brain implant. And they had a chance to put chips on and decide where they were going to invest. And we talked about, well, how would you invest? And what do you think of this neurotech? And then we went back again, and a second day, we made a report card for neurotech developers. What do you want to know about this technology, and who do you trust to provide this information? I want to leave you with what was the most common answer to this question. Who do you trust to do the report card, to give you honest and frank information about the neurotechnology? The most common answer, no one. We don't trust anybody. You as surgeons are in a remarkably privileged and important place. You have a word that carries a lot of power in our society, in our community, and it would certainly matter in marginalized communities like the ones we're working in. So I think about using that power. You are people that I hope they will trust if you kind of work with us in this community engaged work as we all work through these incredibly difficult, vexing ethical questions. So thanks for allowing me to raise them. And with that, I think I only went 2 minutes over, which is pretty good, Dr. Williamson.
That's great. That's perfect.
All yours.
Dr. Shen, thank you so much for sort of opening that those ideas around neurotechnology, just huge amounts of impact that these technologies will have, and really excited, one, to work together, but also to share the work and engage all the audience in the work that's going on in terms of neurotechnology justice in the future. For those that are listening in, absolutely interesting and lots of great comments. Please feel free to put those comments in the Q&A. We're going to have a Q&A session at the end, and so we'd really love to have this discussion, and don't think your questions are being ignored. We're keeping track of them, so go ahead and just keep them coming. Our next speaker is Dr. Gabriel Lazaro-Munoz. He's an assistant professor of psychiatry and global health and social medicine at the Center for Bioethics and the Department of Global Health and Social Medicine at Harvard Medical School, as well as at Massachusetts General Hospital. Dr. Lazaro-Munoz combines his background in neuroscience, law, and bioethics to examine the implications of emerging biomedical technologies in neuroscience and genomics. I think now you can see why Dr. Shen and Dr. Lazaro-Munoz work together, because I think there really is a great synergy in terms of the work he's doing. He's PI on several funded studies through the Brain Initiative from the NIH, too many to list actually. And Dr. Lazaro-Munoz currently examines the ethical and social implications of the integration of psychiatric genomics into clinical care, embryo screening, the development of neurotechnologies such as deep brain stimulation, and the use of deep brain stimulation in the pediatric population. He's a member of the Genomics in Society Working Group of the National Human Genome Research Institute and International Society of Psychiatric Genetics Ethics Position and Policy Committee. He's developing the Latin American Bioethics Consortium to strengthen bioethics infrastructure across Latin America, and is a co-founder of the Harvard Neuroethics Hub. He's also adjunct professor at the University of Puerto Rico School of Medicine. I didn't know that. And Baylor College of Medicine. He has been quoted in the LA Times, Scientific American, Stat News, National Radio, MIT Technology Review, and more. And he received his training as a PhD in neuroscience at NYU, and a JD and Master of Bioethics from the University of Pennsylvania, and a BA in psychology from the University of Puerto Rico. So without further ado, thanks so much, Dr. Lazaro-Munoz, for being here.
Thank you, Dr. Williamson, for that beautiful introduction and for the invitation. All right, let's get started. So I'm going to talk about emerging neurotechnology and emerging surgical ethics challenges. And over the past, maybe you share this perspective with me, but I think at least there's some portion of of the population will soon, and I won't define soon, but enter into this sort of brain implant era, where brain implants are at least going to become much more common than what they are right now. And I'll explain what I mean by brain implants, and we'll talk about deep brain stimulation systems. But there's a lot of investment in this area, a lot of private investment, a lot of investment by the Brain Initiative and NIH. So there's a lot of interest in trying to find ways in which we can stimulate the brain or record the neural activity data and better understand a person's symptoms, to time those symptoms to different biomarkers that may help us manage those symptoms better. And this is generally intended for individuals who have treatment-resistant conditions, often movement disorders or psychiatric disorders, but these are treatment-resistant conditions. And so patients have tried a number of different medications, and I'll give you one example in a couple of slides. But these are patients that have tried a lot of things for many years, have very severe conditions, and nothing is really helping with their symptoms. So they often will, some of them will participate in these trials where you can get deep brain stimulation of particular brain regions depending on the health condition. And for movement disorders, it's been working really well for Parkinson's, for example. And there's a lot of interest in understanding how this could be used in the context of psychiatric disorders as well. It's used for seizure disorders, as Dr. Shen brought up earlier as well. But one thing that I always bring up, in addition to all these different health applications that are currently already being used, there's an interest in everyday tasks and enhancement. So there's an interest in figuring out ways that we could use neurotechnology. And Neuralink has been pretty vocal about this. That's one of the companies owned by Elon Musk. People, are often curious about this company in this context, and they, they've been pretty open about, the possibility of, yes, perhaps having their devices used with patients, but definitely a lot of interest in also, and I guess it makes sense from a financial standpoint that to instead of going for a market that's relatively smaller, right? I mean, a patient population versus potentially whoever can potentially afford this, if you're gonna do it, if they're gonna use these devices for everyday uses and potential enhancement, etc. One of the examples that Neuralink has on their website is texting and browsing the web, ways in which we could connect our brain to some extent, and allow us to make certain, facilitate certain functions like browsing, etc., with our neural activity, as opposed to, I guess, perhaps, for example, using our thumbs, etc. So this is something that's definitely an interest among certain companies and certain investors, and it's part of the reality that we're seeing, and the interest in pursuing these technologies. Now, I'll tell you briefly some of the differences between these devices. So what's currently available, it's relatively more limited, but it's working really well. So you can see in this is a device from Medtronic. The battery goes on the patient's chest, and it's like a 2 inches by 2 inches, and you can see the electrodes here implanted for, this is intended for the ventral striatum for a patient that has this patient had treatment-resistant obsessive compulsive disorder. And so that's the placement location of the leads that will deliver the stimulation. And then the idea with Neuralink, this is an earlier version, but what they're trying to do, and not only this company but other companies that are in this market, are trying to develop electrode leads that have more contact, so that you can record activity from more regions of the brain, and at the same time stimulate in more regions of the brain than right now. You can see see the one on the top has about 4 contacts on each side. So they're trying, the idea, a lot of these companies, even Medtronic, they're trying to increase how much we can communicate with the brain and in which ways we can stimulate. So so this is part of there's definitely a lot of interest in increasing our capability. And so right now this is showing you an example of how a conventional deep brain stimulation system works. So let's say if we're trying to treat or manage symptoms of obsessive compulsive disorder, the leads are often placed in the ventral striatum, and you turn on the system, and the system continuously stimulates. This is what one of the versions of deep brain stimulation. Now there's an interest in developing adaptive deep brain stimulation, so that you not only stimulate or can write into the brain, but you can also record activity. And the goal is that you can identify a biomarker associated, let's say, with depression, that can signal to the system that there's an increase in the symptoms, or onset of the symptoms, or an increase in symptoms, and that the system, allowing the system to be responsive, so maybe have a baseline stimulation and increased stimulation when it detects that kind of pathological neural activity or the biomarker associated with the symptoms. So this is sort of the future, and what and obviously not just being able to read and write, but more than that, right? Increasing the number of areas of the brain that you can access, so that you can stimulate and potentially gather information and stimulate in different ways to manage different functions. So this is where we are, and now I want to tell you about a particular ethical challenge that I've been examining, and that I personally really care about. These are, so I'll start with giving you this example from patients from a trial of deep brain stimulation for depression. And so generally, and this is to give you a sense of the kind of patient that participates in these trials. So for these patients, they need to have failed about 4 different kinds of medications, psychotherapy. And in many of the cases, in this case, I think it was up to like 70% of the patients had also had electroconvulsive therapy, which for treatment-resistant depression can be effective. But they had also failed that, or had not been, their symptoms had not improved with electroconvulsive therapy. And on average, they've had these symptoms for 12 years. And 30% about 30% of them had suicide attempts. So this is a very vulnerable, I think, population because it is treatment resistant, and all the elements that of this treatment search fatigue and looking for answers. So this is a population that I think we have to be, from a research ethics standpoint, be particularly just have some heightened awareness of the community and what they may be going through, so that we can ensure their well-being when they participate in this research. So one of the big challenges that I want to bring up is that often these patients will participate in the trial. So they'll get so you have to meet certain eligibility criteria. They'll get the DBS surgery. There's a lot of data collection, a lot of visits to the lab to gather data, and then they eventually their participation will end, and the trial may end a little bit later. Now, one of the big challenges that we're confronting in this type of research is that if you have an experimental device, the researchers and the teams can cover the cost of any repairs that the device may need during the trial. They generally can't cover the cost during the trial, but once the trial ends, then they will generally contact your insurance provider and see if the insurance provider will continue to provide coverage for the maintenance of the device. Now, what happens is that these are experimental indications or experimental devices themselves, and so insurance providers in the US can say that this is an experimental application, and it's not, and therefore it's not medically necessary because there's not enough data yet to show that this is a safe and effective device. Now, this is something that is helping a lot of these individuals. So there's a lot of these patients that benefit from the device. And so the challenge is, what do we do with those individuals who benefit from the device, and how do we help ensure that they have access to it? So in the US, there's really no legal obligation to provide post-trial access. There are certain, the Declaration of Helsinki and different reports that basically argue that there should be some provisions for post-trial access, but this doesn't have the force of law in the US, and while definitely can influence what's going on right now, is that we are seeing this situation where patients participate in the trials and then there's no safety net to ensure that they have access. And who can ensure that they have access and who can help in this process? I think some of the people that some of the groups that we talk about and that the participants themselves bring up, and I'll mention that in a second, because we collect data with participants in these trials and researchers in these trials. So funding bodies, for example, could provide the funding necessary to allow for device access. If they don't, you're at risk for losing access to this device after the trial ended, even though the device may be helping you. IRBs will often right now IRBs are basically allowing these trials to happen, oftentimes without a plan for what's going to happen during this we're calling this post-trial phase, when they're going to be living their lives with this device. Obviously, at the same time, if the device activated, making certain biological changes as well to their brains, and there's really no oftentimes no data collection either, and so it's really hard to maintain some contact even with some of these companies. So the IRBs could play an important role here. Device manufacturers could play an important role in ensuring that, for example, when you have an agreement with a group of researchers at a university, the institution can request and obviously negotiate with the device manufacturers that you have, let's say, a certain amount of devices available, or the hardware that you need to provide maintenance for at least, let's say, 5 years after the project is over, for those patients who actually benefit. Of course, health insurance providers providing more coverage would be helpful, and participants themselves, like they'll say that they think that if they can pay for it, that they want to contribute to the coverage of the cost, but they do often think that they should be able to keep these devices after the trial and continue benefiting from these devices. This is, I mean, we've been working in this area, and a number of journalists have also been examining this issue, and so it's not. I guess one of our goals is to do research that hopefully will have some impact in terms of policy, and this is sometimes the ethicists we don't have that many ways to except for our arguments, etc. But using having the media as well being supportive in some of these issues, I think it's helpful. We have addressed some of these issues in certain publications, and I want to wrap up by showing you just some of the quotes from patients about these issues and from researchers. So we asked researchers about post-trial access in the US, and these are researchers who are working in adaptive deep brain stimulation trials. And so 13 of 23, so 50%, 57% expressed concern about how post-trial is currently managed. One of them said, "I think it's a huge issue that we don't have great answers to at this point." Another one said, there's no greater shame in our world than offering a service and taking it away. That's always what keeps researchers up at night. I think that you have to find a way to keep it in if the patient finds it to be beneficial. Most researchers describe ways to improve access. So, for example, noting that insurance providers should, probably have a more active role, and that they can have communications with the insurance providers earlier to hopefully help, ensure coverage. But at the end of the day, it's really up to the insurance provider to determine whether, they consider this medically necessary for the individual. Let me show you some of the things that the patients say. So when we ask the patients, should you be able to keep the device? Basically, most of them say yes. At the end of the study, if it's still working, well, if they want it back, they're going to have to fight me for it. So many of these patients feel very strongly about, obviously, being able to continue access to a device that has been able to help you manage symptoms of a treatment-resistant condition that you've been dealing with for many years. And so just to end with this, when we ask the participants in these trials, who do you think should pay for the continued maintenance of these devices? They start at the beginning, often by mentioning insurance providers when we interview before the surgery, and then when we interview 6 months after, they begin bringing up the device manufacturers more, and the insurance providers less, and so that's an interesting. Some interesting data. I think they start, seeing the role of the device manufacturer in this process, and they feel like perhaps they should have some responsibility for covering some of these costs. And that's it. I'll wrap up there. I happy to answer any questions. I think this is one of those manageable issues, but it does require a lot of collaboration from different groups, including the device manufacturers and developers, but also funders, the institutions that fund this research. So and the researchers. So there's a lot that we can do, but it requires and I think there's recognition that this is something that should be addressed, but it definitely requires the will of many of the stakeholders involved in this to improve the situation. Thank you very much for your attention.
Great. Okay, so I'll have the last talk this evening before we get to our Q&A. And I'm Teresa Williamson. As I mentioned before, I'm an assistant professor of neurosurgery at Mass General, and then also co-chair of the Surgical Ethics Working Group here at the Harvard Center for Bioethics, and the research director for United Against Racism at MGH. I'm going to talk a little bit. We've heard about sort of the policy implications of neurotech and how we can adjust the trajectory of the neurotechnology that we're implementing to make sure that it's more just, about the trial indications, and also some of the big picture issues that we need to be thinking about for our patients. And now I'm going to try to put a little bit of a clinical spin on it to talk about the issues of prognostic uncertainty that exist in neurosurgery, and certainly in all the surgical fields that we do, and how utilizing neurotechnology with diagnostic and prognostic uncertainty can raise ethical issues, and what we should be thinking about as we're implementing these technologies. Just some quick disclosures.
Teresa, sorry, could you switch displays for the? Yeah. Okay.
Great. Okay. Is that better?
Yeah.
Great.
Yes.
Thank you. And so quick disclosures, unrelated consulting. When I talk about things, I always give the disclaimer that I'm a millennial. When I talk about race, I am talking about the experience of social race that's important to me. I believe it's also important to my patients. And then just the caveat that none of us sort of have all the ideas down yet about what we're doing in neurotechnology, bioethics, and public health. But, we have some training and ideas to talk about what is really a community engaged and sort of wide social as well as clinical problem. So the outline of my talk, just going to talk a little bit about the neuroethics principles. Luckily, I was preceded by two excellent neuroethicists, so I don't have to get too much into this. as well as the relationships between neuroethics and neurotech and how they come together in neurosurgical care. And then give an example using traumatic brain injury, which is germane to sort of many of our practices worldwide, and talk about the prognostic uncertainty that occurs in traumatic brain injury as an example of how we might think about using some of these neurotechnologies and what issues we might run into. And then briefly just discuss some ideas for the future of how we can do better related to this. Okay, so Dr. Shen may recognize a couple of these slides that he shared with me for a talk in the past that I continued to borrow. But basically, you know, this idea that neurotechnology is this huge industry, and that most people are really trying to do the right thing with neurotech. They are designing companies. We've talked to lots of founders when it comes to sort of company development around neurotechnology devices through our Neurotech Justice pilot project from the Dana Foundation. And really the idea is let's make humanity better. Let's make people more well. Let's help with performance. Very few or none, you know, sort of talking about negative implications related to these ideas. And so I think overall, the idea is that we want to take all this data and this new development and new technology and use it to make real life decisions that are good for patients. And so how exactly do we do that? And how do we make better decisions? We align them with the science, and we do so in a bi-directional fashion, engaging in communities and not just, you know, our community as academics, but really trying to be broad and thinking about the people that these technologies will influence. If we do that, we'll have better outcomes that are aligned with justice. And so the neuroethical principles that I think are really important when we consider neurotech is this big picture idea of justice, and then also this idea of autonomy. So the patient being able to choose, or the patient's surrogate being able to choose really what's best aligned for them in terms of treatment and what they're ultimately going to decide they want to do. And I think prognostic uncertainty makes both of these a bit complex, and I'll show you why. And so just a reminder, I did my training at the University of Chicago with Dr. Siegler in ethics, and I can't do much without talking about his and others 4-box model, where we think about, you know, the clinical indications for any device that we're doing. And so these being the principles of beneficence and non-maleficence, we're going to try to do something good. We're going to try not to harm anyone. And the key questions when we're evaluating that from an ethics standpoint are, what are the probabilities of success I've highlighted here, as well as what are the plans in case of therapeutic failure? I think Dr. Lazarimuna has talked a little bit about, you know, what are we going to do with these devices long term? What are we going to do if these devices don't work? Or what if they do work and we can't support them anymore? And so really thinking about these clinical indications is complex because of the fact that we don't have all the answers from a scientific standpoint in the beginning. Then we have the patient preferences issue, which can be similarly complex when we don't know all of the long-term outcomes related to this. And also it's very intimate and personal when we're thinking about the brain, the mind, thinking, and giving that access to that data. And then further, if the patient's not is incapacitated, which is common for a neurosurgical patient, who's the appropriate decision maker, and have they expressed any wishes? And how do we evaluate something that's not completely clear in terms of whether or not it will improve the patient's quality of life? And that gets us to quality of life, which is, what are the prospects with and without treatment for return to a normal life? Are there any biases that might prejudice the provider's evaluation? And I would take that further to, as we have done our trials, were there any biases that would have affected that to see whether or not that would improve someone's quality of life? And then the contextual features, the societal features that we've talked so much about already this evening that are critical as we think about this principle of justice and fairness for implementing new neurotechnologies. This is from our Dana Center pilot grant, and was already mentioned this evening with our work with More Than Words, an organization for system-involved youth here in the Boston area. And we really, you know, worked with just amazing, brilliant group of youth to talk to them a little bit about who they trust to make decisions surrounding new neurotechnology, how it's going to be implemented, how the data is going to be saved, where it's going to go. and this common answer of no one of who they were trusting. And so I stole this quote from a medical student, and unfortunately, I don't even know their name. It was just in a panel, and one of the questions that she asked was, what about the trustworthiness from what we did yesterday? And so what is our obligation to teach, correct, advocate for justice? And I think, when we saw some of these historical examples that Dr. Shen gave, we are not necessarily trustworthy historically, but what about also our institutions and what we're doing on a day-to-day basis? So how are we going to go about advocating for justice and advocating for patient autonomy for all of our patients, knowing that some of these institutions have a difficult history when it comes to being able to implement new technologies in a just way? So I'm going to give the example of traumatic brain injury to talk a little bit about these principles of autonomy and justice in the setting of prognostic uncertainty. So this is a study that we did a few years ago where we actually interviewed about 140 neurosurgeons with an average experience of around 13 years, so out of training in practice. And we asked them about a very common neurosurgical problem of a trauma. And this was done at the Congress of Neurological Surgeons. The predominance of the neurosurgeons interviewed were from the US, but there was some international representation. And so we asked about an older patient who presented after a mechanical fall with a head trauma. And we showed this picture of what would be considered an operative head bleed of subdural hematoma, meeting criteria for midline shift and size for evacuation. And then we said that further that the patient had a pretty poor neurologic exam without opening eyes, with posturing, sort of mostly reflexive activity. And this is the reason why we chose this case, is because it's very possible to believe that some patients would not survive in a quality of life that they would want following this injury, depending on how they defined that and how the surgeon defined that. In this case, we were only asking about surgeon opinion in the survey. We were not asking about patient preference. And so it's commonplace that the neurosurgeons at home, while a resident is evaluating these patients in the academic setting. And so the resident might say over the phone, what do you think I should recommend to the family? And so we asked the attendings in this case to say, what is it? What do you think you should do? And we gave 3 sort of choices about comfort measures, admitting to the ICU and taking a patient to the OR, and then further asked how they thought that patient was going to survive. So this getting at this idea of prognostication and how it links to decision-making regarding a neurosurgical care. And so this is all the participants of the study. As you can see, about 138 total that completed the entire survey, their experience of around 13 years, the gender breakdown being reflective of neurosurgery in general, similarly with the racial breakdown, training level, and the type of hospital they worked at, with the majority working at a level 1 center. If you were curious kind of what the prognosis would look like from the best outcome calculators we have available, one example was the CRASH calculator, which is a calculator that was made out of the outcome arms of several neurosurgical and neurological studies that showed for this particular patient would have a 14-day mortality risk of about 66% and a 6-month unfavorable outcome risk, and I'll talk more about what that actually means, of death, vegetative state, or severe disability of 93%. We provided half the neurosurgeons that answered the study with that data, so they would have a little bit of a scientific understanding, albeit a limited scale, to understand what that prognosis was. And then we asked neurosurgeons, what do you think the odds are of this patient surviving for 30 days? And that's this data here on the left. And so you can see anything from 0 to 100. And I think the thing is, it would be one thing if you just had a couple outliers. Each dot is representative of a surgeon that responded. However, you can see that this is really just spread, this 30-day survival. And then in black are the dots of folks that would offer surgery and that would not offer surgery. And in red are the dots of the people that would. So, and on the left, these are people that did not have the calculator estimates. And on the right, these are people that did. So you can see, regardless of receiving scientific information about prognostication, neurosurgeons with a lot of experience were extremely spread as to how they thought patients would do at 30 days. And similarly, at 6 months, with little change or moving of the metric by receiving the crash calculator, just a borderline significant change to be a little bit more pessimistic if they received those estimates. And then a real spread about how they would implement technology, whether or not they would offer someone surgery. And so I think this really gets to the point that there is a lot of prognostic uncertainty in neurosurgery, and that its influence or association with surgical decision making is not totally clear at this point. And so we looked a little bit further about what are actual neurosurgeons' views? What do we think about recommending craniotomy? And how do we feel about what we've done? And so it's really interesting that several people agreed that they recommended surgery when they shouldn't have. 41 or 42% of folks, surgeons, thought that. And this is just sort of asking, in all toll in your clinical practice, do you feel like you did not recommend surgery, but you should have? Most disagreed, but some did agree with that. Do you feel responsible if a patient dies? The majority actually disagreed with that statement, meaning that, in general, patients with severe traumatic brain injury, many felt that, if they died, it was sort of the disease process itself. Are you responsible if the patient survives in an unacceptable state? So this is getting to that idea of autonomy and that principle of what it was the patient's goals and their quality of life goals. And many agreed with that statement. Are you obligated? Most disagreed. And do you worry about the incorrect prognosis? So this is one where the majority of participants agreed that they were worried about prognosticating incorrectly. Up here, you'll see a little bit about neurosurgeons' personal views of some of these health states. And I think the reason why this overall is important is because it gets to the idea that we as neurosurgeons we don't agree on what an acceptable quality of life is, which we shouldn't necessarily be expected to. But our data may reflect some of that variation in our personal views and our personal values surrounding quality of life and outcome. And so how does that actually look in practice? I'll just breeze through this because I don't want to get too deep into the data, but we looked in the National Trauma Database here in the US at almost 50,000 patients, 10,000 of which were, or close to 10,000 of which ultimately had a variable coded in this data set for withdrawal of life-sustaining treatment. And we looked at what the predictors were of that, expecting that patients that were sicker would be more likely to undergo withdrawal of life-sustaining treatment. And what we found is that was true, but other things that were associated with that were also race, with Black patients being less likely to have withdrawal of life-sustaining treatment, as well as payment status, and the type of hospital you went to. And so this gets at this interplay between prognostic uncertainty and injustice, potentially, that maybe folks from different backgrounds are not having goal concordant outcomes, and maybe there's some systemic factors that are playing into the care and ultimately the treatment neurosurgical patients are receiving with severe TBI. And so I'm going to transition a little bit to some work that has been done in our system. This work borrowed from Dr. Bodine on a study that we're collaborating on, where we think about what are different ways to talk about outcome, given the fact that we clearly don't have prognostic certainty. And so what if instead of saying, this is going to be an unfavorable outcome, what if we talk about something more like what's a minimally acceptable outcome after severe TBI? And so she raises these questions of what would you consider to be a favorable outcome? Would it be death, survival with permanent unconscious, recovery of some consciousness, recovery of most of your consciousness, recovery of communication or orientation, independence, ability to function outside the home, or full recovery, sort of working through that scale. And interestingly, when we look at unfavorable outcome, we're really separating these into large categories, and these things are pretty distinct and different. And so as we use these, this is what we use for a lot of our trials around TBI when we're thinking about new devices, when we're thinking about what we should use. Our data is not particularly granular and doesn't completely capture what's happening in that moment when you're talking to a family member about whether they'd like to pursue an intervention or not. And so she and others raised this idea of what if we talked about a minimally acceptable outcome? And so instead of saying and actually when she looks at this data of favorable versus unfavorable, or minimal acceptable versus not, you actually see people respond differently. So just changing the words as to what would you find acceptable can change what people will do. And so I think this really speaks to the idea that we can do better when it comes to communication. We obviously want to do better when it comes to our science, but we can also do better when it just comes to our communication around the acceptability of an outcome versus the favorability of an outcome, and see different engagement with devices and with technology. And so this something else to think about when we think about this idea of autonomy, what we would be hearing and how we would be making a decision, but then also about justice. How would this decision change if you're the patient's parent, if you're the neurosurgeon, the neurocritical care attending, the emergency room physician, the social worker, the nurse? And they've shown that there are differences in people's responses. Or an investigator designing a trial that wants to use a device, right? Like, what would be an acceptable outcome in that case? How would it look when you're prognosticating initially versus when you're prognosticating at 6 months to a year, where the American Academy of Neurology suggests that we should be waiting to prognosticate because of all the uncertainty that exists? This is a perspective that I wrote in the New England Journal about exactly this topic of who you're talking to, how you're talking to them, and how that might influence the decision. Talking about, in particular, myself being from an African-American background and talking to other patients of African-American descent, and how sometimes that our conversation might look different, and the prognostic discussion might look different, and ultimately the decisions might look different, and how we can go about doing a better job of communicating, knowing that we're not always going to talk the same as our patients, but how we can do a better job of better understanding this communication around uncertainty, having some cultural humility in that process in order to have better justice and better outcomes in the end, more goal concordant. And then the final point I'll make about this is just this idea of innovation interacting. So while all this is happening and we're trying to perfect our communication when it comes to prognostic uncertainty, we're also discovering new things that are really important to discuss with our patients. So this is this idea of cognitive motor dissociation after severe TBI, that actually when we put patients through a scanner and do fMRI, even though they look comatose based on our cursory exams, they may actually have areas of the brain lighting up in response to the things that we're saying. So they may actually be interacting with the environment more than we think they are. And this may explain some of the delayed awakening from coma that we see following severe TBI. And I'll just leave with the question of, how does that interact with our decision making? What if you're in a hospital where they don't have access to this type of technology to establish whether or not someone might have cognitive motor dissociation or might truly be in a coma? How is that going to impact what technologies you're going to use, whether and how aggressive you're going to be with their treatment? And I'll just echo Dr. Shen's another stolen slide from him about procedural justice, and this idea that during that process, we want to be fair, and we want to be thinking about involving people from all perspectives so that we can do the best job of understanding what the impact of the way we talk, the way we think about this data, the way we collect this data, and ultimately use it in clinical care. So I think in the future, we need to do a better job of understanding the data, being open to errors in our own judgment, knowing that our neuroprognostication has been far from perfect, educate our trainees to do the same, learn more about discussing with our patients specifically in a bidirectional fashion to understand what different terminologies and different discussions of prognostication might do in the future. And I'll end there, and looking forward to the chat. Thank you all so much for listening. All right, so just working through the questions, I think, one that came up to start, and Dr. Lazaro-Munoz and Dr. Shen, I think you both predicted that the Elon Musk question was going to come up. So let's just go right to it. In the context of Elon Musk's Neuralink proposal, what are the primary concerns surrounding the potential for brain-machine interfaces? How should we approach the balance between technological advancement and preservation of individual agency, privacy, and identity?
I can take a stab at I guess I'll start with the first. I think primary challenges. It depends on the potential, on the use, right? On how developers want these technologies to be used and what kind of policies do we have around them. The truth is that there's not a lot of regulation around this. Obviously, you need to in terms of like the different uses. Obviously, there's the FDA, and you need to meet those criteria of safety and effectiveness if it's for clinical applications. But I think one of the challenges that we'll see is what will happen if we start moving towards more kind of everyday uses, and there's obviously, first of all, a big challenge in terms of equity, right? There's going to be only a very small percentage of the population that's going to be able to access this kind of technology. So how we manage the inequities that may create is something that we definitely want to take a look at. But I think in terms of privacy, which is one of the issues that you brought up, the more information that we can gather from the brain, and the more data that can be collected by these companies while you're behaving in your home, driving your car, etc., going to work, the more data that they can gather and correlate to different brain activity, the more they're going to be able to also modify some of these what may be going on the brain activity that may be happening at particular times. So there's a lot of potential monitoring of that data, potential use, potential to sell that data if you identify connections or correlations between certain activities. So I think there's a lot of things that we need to really start paying attention to. Obviously, there's an AI component to this in these devices, a big AI component in this. So there's going to be a lot of discussion about how to manage AI generally, but there's going to be a lot of debate about how we manage the AI within these devices as well.
Yeah, I would just add, I sort of agree with you've just said, and I would add that we're at a moment where we've already transitioned, if you just think over the last couple of decades, to a world in which devices were big and far away, then they got small and nearby, but you had to hold them. And then we're in a moment right now where things are wearable and they're almost implantable, which is, if you go to the grocery store next time, many people have something in their ear, which would have been, completely out of the ordinary, even just 5, 7, 8 years ago, certainly a couple of decades ago. And where the next step is are implantables. And that's why neurosurgery is so important. You will be, and they'll be connected. So implantables, we would connect it to wearables and connect it to sensing devices. This is already starting to happen in the name of science and in the name of medicine. That's a good thing. I think the question about Neuralink is really a question about broader industry. There are a lot of other non-Neuralink, not as well-known neurotech device manufacturers who are far ahead of Neuralink, frankly, in different ways, and are focusing on different diseases. So there's going to be a proliferation. And I think it will be a combination of actors. Of course, there's the government potentially, or state regulators, international regulation. But neurosurgeons are gatekeepers. They clearly are gatekeepers. And you'll need to think about whether, again, or not, depending on how you think technology is or isn't going to be used, you're going to sign on for doing certain procedures. And I think what we will, again, see, and I was trying to hint at this in my talk, is that even further blurred lines between medical devices and everything else, consumer devices. Certainly, we've seen that already. Here's one. Here's a medical device right here. I think you all are holding one, or it's pretty close to you, right? And it's really difficult to regulate, or even to think about ethically what to do when you've got this awesome power, which is kind of sort of, medical, but also kind of sort of not.
Yeah, absolutely. Somebody actually asked about the idea of iPhones, and I think that really gets to that idea. It's tricky, right? Because talking to a patient about that is also tricky, right? So the idea of whether or not you're going to do it, but then how are you going to talk to them? And so someone asked about, what does informed consent look like when we think about going from wearable to implanted technologies, who we're implanting them in, particularly when it comes to those with neuropsychiatric disease. I'd let either of you take that, and then maybe I'll try at the end.
Yeah, I could start on it. This was we thought a lot about this with the group of fellows that I mentioned in the talk. I've always liked the common rules approach, which essentially says you ought to do what a reasonable person would want. And it's hard to know that, but I think the key to getting there is procedurally trying to engage with reasonable people in the community to think about, and I know, Gabe, you've done a lot of this with patients and as well as Christine, like, what do you want to hear? Informed consent has moved, unfortunately, and it's due to the law, into something that looks more like, a 20-page document, and you sign all this. And the longer and more complicated it gets, the less likely that, in fact, there will be informed consent, even though you're providing more information, right? So ironically, giving more information might not necessarily be the right thing. But there are a lot of mechanisms out there, and in other fields have been developed for effectively communicating, and those can include short videos, those can include graphical formats. I think the ethical tension is how much you weigh the benefits versus the cost, because yes, there are potential surveillance concerns, but many of the procedures you're doing are life-saving or life-altering, and that's a real trade-off as well. So there could be significant cost or concerns, and yet it would still be really valuable to go through with the procedure. So but I think that, especially on the AI side, there's an emerging world that neurosurgeons should be aware of that's happening. It's just trying to think about this generally. How do you communicate the complexities of AI in the sort of informationally, the soup that you mentioned, Teresa, about uncertainty. And I think you try to emphasize transparency, and you try as best you can to engage the community and use some empirical measures to see what they in fact want.
Yeah, I absolutely agree with that. And I think the consent form, high level, obviously a legal document that holds sort of different standards depending on where you are and where you're practicing. But I think for me, it's that conversation of, do you really understand what the using sort of Gretchen Schwarze's framework, what the best case is with this, what the worst case is with this, what the most likely thing is to happen. And I think here there's this almost like futuristic potential, right? Of, okay, well, let's imagine this, because I don't think, when we think about like the invention of Facebook or something like that, everyone was thinking 20 years down the line as to what the possible societal impact would be. And this is even trickier when it's something kind of implanted in someone's brain. And I think, Francis, everybody was wondering, kind of $1 million question. We got it a couple times about this idea of who gets access to the data. You teased us a little bit with this experiment, and can you talk to us a little bit more about who's going to get access and how you see it would potentially be used, particularly in courts, maybe?
Sure. So the law 101 is that the government, so long as they hop through some procedural hoops, can access a whole bunch of information about us in so let's take a different context. So let's take a criminal context. That was, I set it up that way deliberately. The rules are a little bit different when one member of our community has been accused of hurting another member of our community. And the basic idea is that some of the protections we usually enjoy, government can't just come in and read my journal, government can't come in and search my house. Those disappear if there's, a certain reasonable suspicion and they've got to meet some other procedural bars, then they can. And we've all seen that on TV or the movies, right? I've got a warrant to search your house. Okay. I've got a warrant to search your phone. Okay. I can take your physical fingerprints. You've seen that, right? Even if you resist, I'm going to push your fingerprints down. Brain data lies at this interesting, but here's what we can't do. The police cannot come in and force you to talk. Right? You cannot be forced to talk. You have a right against self-incrimination. It's called testimonial evidence because you're giving testimony. And, we've again seen it all on video, right? I take the fifth. So you've got a Fifth Amendment right. You've got some protections against the government taking your testimonial evidence, but you don't enjoy those same protection against your physical evidence. And so one of the thorny questions that scholars and courts a little bit are starting to look at is brain data physical evidence, like your fingerprints? Is that DBS recording like a brain fingerprint, like your GPS location? The government can certainly take your phone and identify your GPS location. Indeed, it's one of the ways that police do their work to try and figure out where you were on September 19th, 2023. If it's the case that it's physical evidence, then assuming that there's probable cause and a few other oops, they might be able to get that data. If we think that it is testimonial evidence and that it's a lot more like you saying something, it's your mental thoughts, your mental actions. I shouldn't say that, rephrase, your thoughts, your mental activity, then you have potentially more protections, at least under the US code. So this isn't, a lot of us in the world of law and neuroscience think about this. It hasn't fully been vetted in courts yet. It will need to be. And then again, as a practical matter, there's going to be, let's say you could get this data. Well, there are only a handful of people in this world, and you are might be amongst them, neurosurgeons, to know what to make of that data, right? It's not, in that way, it's not like GPS. Well, if so long as the GPS puts it on a map, I can interpret a map. If it's not like video surveillance evidence. I see you taking candy out of the candy jar. This is a bunch of data. I have no idea what it means. Is that sleep state, wait state, angry state? Epileptic seizure state? I don't know. No one in the law will know, right? So this goes back to that kind of medical legal partnership, and a lot of the work that our lab does is trying to build up the relationship so that when we do reach this future, in the not so distant future, we don't scramble and run around with our heads cut off like we're doing with AI right now. So I think it's an open question, Dr. Williamson, and I think it's a really important one that we ought to be thinking about, because it will come. There's no doubt about it.
Yeah, absolutely. I think it's a pretty, it feels far-fetched, but then it also feels, just when you put it in that context, quite germane. So thank you for that.
Could I ask Dr. Laszlo Munoz, though, kind of far-fetched, but I know informally there's some indication that in some legal proceedings, potentially DBS, like, isn't this? It's not published yet, but it's like happening, right?
No, but it's happening. Yeah, I mean, there have been researchers that have expressed concern about courts requesting data from deep brain stimulation devices. There have been cases, for example, so what I think is going to be really interesting in terms of that legal question is, well, which is kind of along the lines of what Dr. Shen is saying, but it's going to be that it's not going to be, I think the decision is not going to come down to whether we allow the courts or prosecutors, etc., to have access to brain activity data kind of in general. It's going to be more related to what that brain activity data is telling you. For example, let's say, someone there's one case where an individual had I think it was this guy. So this was a pacemaker, and they were, and the police were the prosecutors were accusing this individual of arson of his house, and he claimed that he woke up and there was this fire at his home, and there were some questions about the story, and they actually requested access to the pacemaker data, so that they could tell whether the individual was asleep or not at that time when the individual said he was asleep, and the data suggested that he was not asleep. So that was part of what it became the case against this individual. So that's your heart, right? That's a pacemaker in your heart. Many people talk about deep brain stimulation as a sort of brain pacemaker in a sense. So, is there, and I find this really interesting, is there like the few inches that separate, one organ from this other organ, can make a huge difference, right? In terms of the kind of information that we can obtain from both. It can be very different, and in some cases, we will probably get to a point where what we are generating the information, it'll take time. Right now, you may be able to sense, oh, this individual may be at an increased state of anxiety, or there may be some tremors that an individual may be experiencing, and so you can recognize that biomarker. The more we learn about these different biomarkers, there's been research about being able to identify words when by thinking about them. Like right now, it requires a lot of training and a lot of technology to be able to figure that out in a way that you could apply it just like out and about, to gather information or spy or that kind of thing. But it's something that's where these companies are headed. It's to be able to understand more of what the information that the brain is generating, and what can we do with that information to, in some cases, improve our health, but in many cases, improve other aspects of and I've seen like some people comment about transhumanism. And so that's, I think, eventually we're gonna get to a point, and I see this with genetics as well. Eventually, we're gonna get to a point where I think these issues about how we manage these technologies are gonna become a much more important political issue than what they are at the moment. Both the genetics, but also the neurotech. I think this is moving at a pace that and the kind of at a pace that's just extremely fast, but also the kind of information that we can generate from these and our potential to benefit society, but also for some individual, there's a big financial interest in generating this data and sharing some of this data. So there's gonna be a lot of negotiation between different stakeholders. And I think the earlier, as Dr. Shen mentioned, the earlier we can get to this and we can start addressing these issues and discussing how we want these devices to be used in our communities. And do we want non-invasive, for example, non-invasive devices used in our schools? Like, do we want teachers to be able to monitor whether a child is paying attention, which is one of the technologies that people have tried as well. So I think as we move forward and the technology continues to develop, this is going to become more and more a part of some of our lives, and I think it will eventually become a more sort of political issue that will get more attention.
I love that. And that gets to one of these questions of like any other future conflicts or issues that you foresee. And I think that's one of the three of our sort of favorite mental exercises to do. In fact, one of the biggest things we're doing, and also not just ourselves doing, right? Going out, asking people. We asked at the Museum of Science, hey, asking kids, asking grandparents, what do you see as the future of neurotechnology? If you had an ear sensing, mood sensing earbud, would you invest in it? Why or why not? What would be the downsides? If you could do a saliva test to test for potential future mental health issues, why would you do that? Why wouldn't you do that? And I think it's really important that, what we foresee being complex, but also kind of what the general population does, so that folks like us who straddle these worlds between ethics and neuroscience and neurosurgery and the law can not only just help to foresee them, but also to make sure that the trajectory is for a positive impact. And I think that also gets to this idea of how we prevent it from being exploitative to the patients in question, particularly as we try to improve access, because the worst thing we could do is improve access to something that potentially does harm to a community, and then they're therefore sort of stalling the progress of neurotechnology in general. I think there was another couple questions, Dr. Lazarominas, for you about clinical trials. Sort of what are some of the downsides and potential side effects? And then someone was also curious about how much a device costs post-trial, ballpark. I think you know this because I think I heard you speak about this at another occasion.
Yeah, so the cost of implanting the device is around $40,000. Maintaining the device, it depends on and this gets to one of the issues about concerns about side effects or adverse events, for example. There's a lot of not a lot of concern. It happens in about, let me talk with numbers. It happens in about 4 or 5% of cases. There may be infections, and the infections are rather difficult to manage. So you may do a couple of salvage procedures. Each salvage procedure may cost about $10,000, maybe more expensive, but usually they don't work. So when there is an infection, and it happens in, again, in like 3 to 5% of cases, in children, the infection rate is a little bit higher. But when there is an infection, you generally have to remove the device and reimplant a device. So that would, so in terms of post-trial management, if that was the case, the highest possible cost, if you have to replace the whole thing, would be about $80,000, removing the device and then reimplanting the device.
Yeah, and I think one other thing that's kind of interesting about as we expand the targets for deep brain stimulation in terms of the psychiatric field, and actually we're moving forward, but we're also reflecting on the history that where some of the things that Dr. Shen showed about the violent brain and how we thought we could do lesioning for certain behaviors, and how ultimately that ended in a lot of suffering for individuals that were cared for under these philosophies. I think, one thing that's interesting is a deep brain stimulator can be turned on and off if there are sort of psychiatric or mood or changes, whereas we also now have focused ultrasound technologies and other technologies that are more permanent lesioning, where some of those side effects may not be able to be modulated. And so while there is this like kind of amazing gain of technology, there's also this growing concern about, what is modifiable and what would be a more permanent potential effect as those. I think we have just 1 minute and we have so many good questions. So hopefully we can, folks will just continue the conversation on Twitter, by email. But I think, there was one question for me about AI in withdrawal of life-sustaining treatment and decision-making. I think it's a great tool. I do think whenever we're looking at AI-based data to make decisions, we need to think really carefully about the outcomes. In TBI work and some of our neurotechnology work, our outcomes are not super clear or granular. And then also the data that we're putting in and the potential for biases as we're doing that. And then ultimately it's going to be a guide, right? Because the patients have to decide whether or not that quality of life improvement and their family members is worth it. And Gabe, I'll just leave you with the last questions about whether you think, how do people decide whether or not the DBS device is doing enough to warrant it paying for it post-trial? I think that's a great question. And then for maybe both of you, whether these device companies are sort of culpable for any of their roles, whether it be in maintaining a device or, the device made me do it, those types of things in a legal sense.
Yes, so I'll start with, within the post-trial context, I think the device manufacturers definitely have a role to play. As any other group that's benefiting and that's participating in this. In terms of, sorry, what was the first question?
So the first one was whether or not, like, how do you decide if you have a DBS for depression and you want it post-trial, whether I have to pay for it?
Yeah, so that's part of the debate that we're trying to start. One of the options, so there may be different options. So usually the study will have a criteria, some kind of criterion set already about how much decrease they have to see in symptoms to consider that a effective. But there's a number of people that will also get remission. So it happens pretty often, depending on the indication. Now, how to decide whether you continue getting that benefit? One of the questions is whether we go by a subjective standard or a more objective standard. A subjective would be, do we want to base this on the participants' perception about whether they're feeling better? Let's say because to some extent we don't understand exactly what how this is working, and it may be that you're, for a patient with a psychiatric disorder, that you're improving other symptoms, but maybe not being as effective in improving OCD or depression. So the objectivity or subjectivity that we allow, we could do, for example, having an independent assessment by a clinician that's not involved in the research be the one to determine whether there was in fact a decrease or an improvement. Now, to make this even more challenging, many what many of the studies have seen in for example depression is that it may take a while. It may take a few months, it may take years for an individual to actually see an improvement. So it is difficult to tell someone. We have to think about it more carefully and figure out when are we gonna have these cutoff points and how are we gonna make these decisions. But it's a great issue to bring up, so thank you for your question.
Thanks. And then last one, as we think about, who's responsible for these device-initiated behavioral changes potentially, is it the device manufacturer? Is it us, the surgeon, putting it in? Is it the patient, or is it all three? Any last thoughts on those ideas?
Lawyers look for people to sue. So I would put all of those and all the institutions that you're involved with.
Absolutely.
I mean, I guess from a legal standpoint and legal strategy, that's what people would generally do, right? I think there's a lot of there's a lot of communication and a lot of interest by these companies and the researchers. I think they're genuinely interested in figuring out a way to improve this situation, and I'm sure the institutions. So hopefully there's a lot of other steps that we can take before that kind of action. I'm sure there's a lot of communication and a lot of goodwill that we just have to continue working with.
If I could just add as a last thought, I think the biggest threat is not lawsuits, but is a horrible narrative gone wrong. And I would suggest looking at electrical therapies and depression as sort of the example of a treatment that really works, that nobody wants to get because it sort of took on a cultural thing of its own. And I can imagine 3 of these surgeries going wrong, and then suddenly nobody wants to get the implant, even though it does as it springs up. I mean, so that's my thought. But this has been a great panel. Thank you.
Thank you all so much for being here. Thanks for the center staff and the center team and my co-chair, Dr. Hanto, for being here tonight. I think we've heard a ton about neuroethics and neurotechnology, what we can do better in the future, and really the role that all of us have to play, patients, providers, companies, institutions alike, to make this successful and to impact this trajectory positively. So thank you guys so much for being here. And we'll see everybody next week at the next and final session of the Harvard Surgical Ethics Conference.